Hello, everybody. I would like to thank you for invitation, and I would like to thank again for sharing this topic under title Addressing the Discrepancy Between Evidence and Reality, the landscape of hypertension in Iraq. I will discuss with you the challenges. This is my disclosure. 8 challenges and end with whole message. First challenge number 1. Still, we have limited data in Iraq, lack of evidence in prevalence of hypertension globally, or lack in evidence in prevalence of hypertension in subgroup like children, young, women, elderly. Also, there's a lack of evidence in the prevalence of prehypertension and other subgroups. The history of the first registry did in Iraq in 1979, and at that time the prevalence of hypertension was 12. The cutoff value at that time 160/90. And the next step studied it in 2015 by Minister of the Health and revealed the prevalence of hypertension was 35.6, and at the time the cutoff level value 140/90, and there is fairly close prevalence association between men and women. Regarding the prevalence and control of hypertension in diabetic patients, a prospective study did in Basra and conclude that hypertension was seen 90% of diabetic patients in Iraq. Another survey did by Iraqi of Hypertension Society in 2020 found that the prevalence of hypertension was 49 and the incidence of hypertension toward the young age group. Another study did in Kurdistan and Iraq, published in 2020, found the prevalence of hypertension-associated risk factor in old adult, conclude the prevalence of hypertension in Erbil city is higher than 54.7. So what we need, proposed action, need national survey, need sharing data with the near regional countries, and need to encourage postgraduate students to write paper to fulfill the gap in this lack of evidence. Challenge number 2, still no own guideline or roadmap in Iraq, still adopted ESC or ICC or NICE or other guideline, and our population in Iraq differ in lifestyle, in their consumption, salt intake, and in follow-up. Depend on my knowledge, I will recommend to use ISH guideline in Iraq because it is more applicable, because divided the two groups according to the resource, that high income and low income countries, and divide even the treatment to the essential and optimal. And as you know, when compare the ISH with the European guideline, there is a target population difference between what are called optimal care and essential care, and the treatment also differ between ESH and ISH regarding optimal and essential therapy in management of hypertension. So what we need Iraqi guideline, at least MENA region guideline, Arab region guideline, Gulf region guideline, and need societies and stakeholder decision to make a roadmap in Iraq. Challenge number 3. Still, we have poor control of blood pressure, non-adherence to drug, to diet, to sport, and hesitancy in diagnosis and to start treatment. And this is studied by MOH of Iraq and found that the 7.9 only patient will well control hypertension and stick to the medication. And the study did in Suleimaniya found that non-compliance with antihypertensive drugs, found that 54% of hypertension were non-compliant with antihypertensive drugs, 55% male and 45% female. Another proposal study found that, published in 2019, evaluated the blood pressure among Iraqi patients, conclude that blood pressure control was globally suboptimal. The cross-sectional study did in Iraq 2021 under title Relationship between Knowledge, Illness Prescription, and Medication Adherence among Hypertensive Patients, concluded that the rate of medication adherence was affected by many factors, including lifestyle, diet, number, and side effect of medication and complication that caused by hypertension. So in general, we found that the adherence might be a multifactorial, might be related to the patient, therapy, condition, healthcare system, and economic state. What we need educational trips and early orientation and follow-up and change in Iraqi healthcare system. Challenge number 4. Hypertension is a chronic disease, not transient. The goal is not to reduce the target, but to prevent the complication and death. There is a challenge regarding the cost of drug, and there is a challenge regarding generic versus brand therapy in management of hypertension. This is a list of price of drugs available in Iraq. And this study published in 2016, compliance of hypertensive patients to the therapy regimen in health facilities. And there is a reason for irregular drug intake, including cost, forget, feeling better, ineffectiveness, side effect, avoid addiction, and herbal medication. And concluded that the compliance of hypertensive patient was highly associated with old age, high level of education, monotherapy, and single dose, and low cost. As you know, then in ISH, then in general, in all guideline, we now not to recommend only use treatment with combination therapy. Can use single therapies, use isolated therapy like use of free combination if single pill not available, or use thiazide diuretic if the thiazide like diuretic not available, use alternative to calcium channel blocker if they are not available or not tolerated. There's a list compare between brand and generic. I found that difference in the price only. Challenge number 5, diagnosis of hypertension, different in devices and no calibration of device. We have a lot of devices to record the blood pressure, and clinically there is a clinical validation. Most of blood pressure devices available are consumed globally, not probably validated. We need to validate it either technically and clinically. And what we need own validation protocol, technical and clinical, supported by ISH, Iraqi Hypertension Society, and Minister of the Health, and cuff size available with each devices. Challenge number 6, lack of sleep, heavy work, noise, stress, disaster, pollution, panic state, all those can cause an increase in blood pressure. This is a study from Al-Kadamiyya, hypertension sample in female physician, found that the prevalence of 30% carried out of 600 female physicians, conclude nearly 2/3 of participants with high occupational stress had hypertension, and higher stress level was among surgical anesthetist department. Another study found that the occupational noise pollution is increased, being recognized a physical factor, and there is an increase in systolic and diastolic blood pressure. This study did in Iraq 2017. And challenge number 7, salt consumption. In Ithaq, this is a study in Kurdistan, Iraq, found that conclude the sodium content of 1/3 of studied bread sample are higher than accepted limit. And what we need salted with 1 whole, green pepper as a salt substitute, potassium supplement recommended, and Himalaya salt not recommended. Challenge number 8, alternative therapy, use of herbal therapy and wrong beliefs. This is a study published in 2015, conclude that the use of complementary medicine, alternative medicine, particularly biological-based therapies, was prevalent among hypertensive patients in Iraq. And 40% of the patient use herbal therapy, and the most common herbal therapy, garlic, was the main type. Use this. This is found in the study published in Basra in 2020. What about wrong belief? They believe headache as a prominent symptom of hypertension. They believe lemon juice reduces the blood pressure. they believe cupping reduces blood pressure, and chicken feed, they believe reduces blood pressure. What we need is education, education, education in different level. Finally, should we update our knowledge and wait promising news? I recommend to depend on adopted ISH guideline in Iraq. Start with combination therapy is the best to treat and control blood pressure in Iraq. Still, hypertension and prehypertension are underestimated in Iraq. And thank you very much.